webinars, okay. Oliver, can you hit continue, please? Okay. Okay. I think maybe you just need to hit continue to get that out of the way.
I have it.
There's a pop-up box.
I don't have that.
Says the webinar. Okay. All right.
Sorry.
Okay. That's okay. We're good. So the webinar is entitled "The Medicaid ACO Demonstration and the Transition to Regional Health Hubs: Implications for the COVID-19 Response." Next slide, please. Housekeeping items. Again, we do anticipate a couple hundred folks joining us for the webinar. All of the attendees lines will be muted throughout the event. If we invite questions, please feel free to put it in the Q&A box. Two other quick items. We are going to be recording the webinar, and I just, that was my flub, Oliver. I had to hit OK for the consent to the being recorded. So if folks can do that on their screen, that would be great. And then we will follow up and post the slides and the recording on the center's website. We'll also be circulating right after this event the feedback form. We are interested in your feedback about the topic that we covered today, but also too about future seminars that we'll be hosting, future forums. So Oliver, the next slide, please. Just a few acknowledgements that are really important. Support for this event was provided by the Robert Wood Johnson Foundation. The views expressed here do not necessarily reflect those of the foundations. I'll shortly be introducing my colleague, Derek D'Elia from MedStar Health Research Institute, formerly of the Center for State Health Policy. I know many of you know Derek, but the work that he'll be talking about and the findings come from a research project that was funded by the Agency for Healthcare Research and Quality, AHRQ. It was an R18 grant. So again, an acknowledgement for the funding support for the project and the findings that Derek will be sharing soon. Also, as well, acknowledge our colleagues, Oliver Lontock, who has been a yeoman's effort to help with the plan and the logistics and the implementation of this forum. I know you've been received several communications from Oliver over the last few weeks, and certainly a few this morning. There were some technical glitches with the Rutgers Zoom account, so he was put through the paces this morning. So for any of you who had a little trouble logging on, thanks for your patience, and hopefully we got that under control thanks to Oliver, based on the fact we have 160 people online right now. Again, we also want to thank our panelists in advance for sharing their expertise and insights. There isn't a group in New Jersey who knows more about the accountable care organizations, the regional health hubs, and the work that's being done in the communities than the group that you're going to hear from this afternoon. So we're really delighted about that. Oliver, next slide, please. Again, just acknowledging our colleagues and our funder, the Robert Wood Johnson Foundation, as well as the Nicholson Foundation, who was also instrumental in supporting the ACO work that we'll be talking about. Next slide, please. Just a little bit about the Center for State Health Policy, and as I mentioned, a lot of familiar names on the registration list. So I won't go into any real detail, but the Center for State Health Policy is supported by the Robert Wood Johnson Foundation. Our mission is to support state health policy in New Jersey, and you can see there are core areas and our project portfolio, what we focus on. Next slide, please. Just a little bit about the goal of the Policy Forum series. We started this in July this past summer. Our hope was to address some of the most critical health and healthcare policy issues impacted by the COVID-19 pandemic in New Jersey. Unfortunately, there's a lot of landscape to cover in that regard. We're trying to draw on timely and relevant data, expert discussion, as indicated by the panelists, reflected by the panel that we've convened today, have an expert discussion of policy strategies and thinking about long and short-term solutions. You know, where do we go? At some point, God willing, in the next few months, where some of this is going to be in the rearview mirror, and the promise of the vaccine is it's so exciting and you know, allows us to think about what New Jersey is going to look like 6 months from now, and when hopefully the first word that doesn't roll off all of our tongues is COVID or pandemic. So that was the goal of the policy series, the forum. We had one in July that focused on the impact of small employer health insurance, one in November that we convened with a couple of hundred colleagues and attended by a couple of hundred colleagues, and that focused on the impact of treatment and services for those afflicted with substance use disorders. We have this session today, and we have 2 that are planned for the spring. Our next one we're really excited about. We're thinking no date has been set, but probably April 2021, looking at COVID-19's impact on New Jersey families, and that would be broadly addressing some of the other social determinants of health and housing, food access, and such. And another one is the strategies to address barriers to workforce and program licensure. That'll probably be early summer of 2021. We know what the impact has been on the healthcare workforce, and there are a number of, I think, really salient policy issues that we can get under the hood a little bit about. So next slide, please. I'll hand it off now, but just quickly, here are our panelists and presenter, Derek D'Elia. Oliver has circulated their bios, so I won't go into any detail, but Derek, just quickly, Derek is the Director of Health Econ and Health Systems Research at MedStar, formerly of the Center for State Health Policy, one of our faculty. Our colleague, Rob Houston, is the Director of Payment Reform at the Center for Healthcare Strategies. And then our panelists, Rob will be the moderator, and our really talented, insightful, and knowledgeable experts on the panel include Tyler Hausman, VP of External Affairs at the Quality Institute, our colleague from the Department of Health, and thank you for taking the time, Yanai, to sit in on this session and participate. Yanai Kranzler is the Director of Population Health at DOH. Carrie Lagoso Miserel is the Executive Director from the Greater Newark Healthcare Coalition. Greg Paulson from the Trenton Health Team, Greg is the Executive Director, and Aaron Truchill, Director of Analytics at the Camden Coalition. So that's our group. I'll stop there. Again, a warm welcome. Thank you for participating. We'll end on time, and I'll hand it over now to Derek to present some of the findings from his research. Derek?
Great, thank you, Margaret. Can you hear me okay?
Yes, perfect.
Okay, perfect. So good afternoon, everyone. Thank you for joining us on the webinar. I'm going to move through pretty quickly just to give the background, kind of the history of where we've been with the Medicaid ACOs in New Jersey, how they evolved into regional health hubs, and then we'll really lead into the panel discussion of what's going on now and what we think comes next. So Medicaid ACO demonstration in New Jersey, it began with some broad goals that actually attracted a lot of attention nationally. Lots of people from other states were interested in what New Jersey was up to when this demonstration was first conceived and put into place. So the original idea was to do a 3-year experiment with accountable care and shared savings. The goals were similar to the goals of most ACO programs getting started, back years ago. Improve care management, meet quality benchmarks, and develop mechanisms for financial sustainability. Originally, this was designed to be something that would involve limited financial risk to providers. So providers would be in the one-sided shared savings model. So if the ACOs were successful at generating savings, they'd be rewarded for that, but there would be no penalty if costs went up for an ACO during the demonstration. And then the idea was potentially use the demonstration to transition ACOs into a payment model where they might take on greater risk, as is done in other ACO models like Medicare, upon which the New Jersey demonstration was sort of modeled after, but with lots of tweaks and changes to make it more relevant for Medicaid and for New Jersey. And New Jersey's goals, which ultimately were to balance flexibility in terms of letting ACOs sort of develop organically, develop ideas for care management and social service integration on their own, but also provide enough oversight to make sure patients were protected and the integrity of the Medicaid program was protected during the demonstration. And we'll see if we get into some of the details. There was some tension here about how much flexibility can you build in and how much oversight should there be. These things were kind of in opposition to each other as the demonstration unfolded. And also the state wanted to limit its financial exposure. And ultimately, this was a demonstration. So the ultimate goal was to learn from the experience, which we really did. And we'll see that in a few minutes. So we can put up the next slide. So I'll walk through briefly. This is the demonstration timeline. The demonstration was signed into law in August of 2011. Then it took a while to develop the rules for the demonstration. There was comment period, response to comment. Lots of technical work had taken place. It wasn't until July 2015 that the demonstration began officially. And when it began with 3 ACOs that were certified to participate in the demonstration. And participation involved lots of benefits to the ACOs and lots of rules, which I'll get into in a minute. But a key point in the demonstration was in February 2016, the ACOs received their first round of Medicaid claims and encounter data from the state. And then the first demonstration year had ended in June of 2016. But it was decided later that the ACOs, in order to do the work that they were going to do, to build the infrastructure, to really do this seriously, they were going to need some funding from the state. So at the beginning of demonstration year 2, there was a $1 million appropriation made to each ACO. And then the rest of the timeline is sort of self-evident. Each year, the demonstration was renewed. There were new appropriations for the ACOs, $1 million each. Demonstration was supposed to end after 3 years, so that would be June 2018. But because funding and other things got off to kind of a late start, the demonstration was extended for an additional year in July of 2018. So it didn't really end officially until June of 2019. We can move to the next slide. So I mentioned the ACO model in New Jersey attracted a lot of attention nationally. And this is because the New Jersey model had a number of distinctions that really made it different from the other ACO models that were emerging in a number of other states. So one distinguishing feature was patient assignment. So in New Jersey, ACOs could really choose their geography as long as you had at least 5,000 Medicaid enrollees in your geography. And if the geography made sense, it had to be approved by the state. But ultimately, there was a lot of flexibility here. In other states, you would either have an assigned geography, a county or a collection of counties or something like that, or patients would be assigned by a patient assignment algorithm, similar to what Medicare ACO programs had been doing. New Jersey was quite different in terms of patient assignment. Another distinguishing feature was managed care organization participation. In New Jersey, participation was completely voluntary. This was part of the kind of flexibility and the idea that things would develop organically. ACOs would sign agreements with managed care organizations, and we would see how it goes as things evolve. That's very different from other places. Other states, they either mandate all the MCOs participate, or they make it a fee-for-service program, and managed care organizations are just excluded, similar to the way Medicare Advantage is not part of the original Medicare ACO programs. Also, the spending that gets counted for shared savings is a bit different. In New Jersey, in fee-for-service Medicaid, this was designed to be a total cost of care program, which included pharmacy spending, long-term services, and support. For the MCO portion, that would be negotiated. But at least on the fee-for-service side, this was quite different from what we saw in other states' Medicaid ACO models. Typically, you would see defined categories of spending that would be eligible for shared savings. Typically, hospital use, emergency department use were the types of spending that were targeted. Or other approaches might say, we're going to look at total costs of care, but we're going to carve out certain things that we think the ACOs should not be responsible for. Behavioral health, long-term services and supports would be common carve-outs in other state programs. We can go to the next slide. So here are some of the key implementation features and requirements under the original demonstration. So to be an accountable care organization in the demo, you had to have a multi-stakeholder board that had broad representation in the community. You had to represent healthcare providers, social service agencies, and you also needed patient and community representation on the ACO board. There were shared savings requirements, definitely required under Medicaid fee-for-service, and I can certainly remember the Rutgers Center for State Health Policy had worked closely with New Jersey Medicaid in developing an outline of strategies and requirements that had to be met for shared savings in the fee-for-service portion. In the Medicaid managed care portion, that would be negotiated between the MCOs and the ACOs. And that's really important because once this got up and rolling, Medicaid managed care represented nearly all of the Medicaid population in New Jersey, at least 90%. So the voluntary nature of these arrangements became really important to the ultimate execution of the demonstration. There were quality metrics put together. ACOs could choose from state-endorsed options. There were essentially a menu of some required options and then a menu of options that ACOs could choose from. And again, that was on the fee-for-service side, which was a bit limited. On the managed care side, this would be negotiated with the managed care organizations. And then another requirement is you needed sufficient provider participation based on the geographic area of the ACO. So to be an ACO, you had to have all of the hospitals in the area participate in the ACO. You need to have at least 4 behavioral health care providers, and you need at least 75% of the primary care providers participating in Medicaid. They had to be part of the ACO in order to be officially certified as an ACO under the demonstration. It turns out these requirements were not easy to meet. A number of organizations across the state, I believe it was 7, had applied for ACO certification. Ultimately, only 3 ACOs could meet all of these criteria, but the ones that did would be part of the demonstration. They would receive monthly data feeds of Medicaid claims and encounter data, not just for their own providers, but the important part about the data feeds is that the ACOs could see patients who were receiving services outside of the geographic area or outside from providers who were outside of the official ACO group, which is really important for managing services and predicting spending and utilization and things like that. We can go to the next slide. So as I mentioned, ultimately 3 communities were certified. Camden Coalition of Healthcare Providers, Trenton Health Team, and Healthy Greater New York. Communities that had applied for certification that did not meet every single one of those requirements would not be eligible to participate in the demonstration. However, there was a group, the Healthcare Coalition of Passaic County, that was really interested in continuing on with ACO-like activities, and they certainly did. They kind of shadowed the demonstration, and they did so without state resources. Notably, they received substantial support from the Nicholson Foundation to do similar work for their communities. But a big gap in their resources is that they did not receive the regular data feeds from New Jersey Medicaid. And it's also worth pointing out that each community had begun the demonstration with different levels of coalition experience and activities. Certainly the Camden Coalition had been doing all kinds of similar activity for many years before the ACO demonstration had gotten up and running. Trenton Health Team had some experience as a coalition. Greater Healthy New York, a bit less. And so you'll see in the reports we had done on this, we looked at the demonstration overall, but we also broke out progress that each of the certified ACOs and Passaic County had been making as the demonstration had evolved. But for today's discussion, we're going to keep it high level and just talk about what the ACOs had done and accomplished and how they evolved overall as a group together. Next slide, please. So in terms of size of communities, here's what the communities looked like in calendar year 2015 when the demonstration first got started. So this shows you how many people were enrolled in New Jersey Medicaid in each of the demonstration communities. And here I mean Medicaid and the CHIP program. This shows how many people had at least one day of enrollment in Medicaid CHIP in each of the communities. So we're talking about, in the 50,000 range for the certified ACOs and about 43,000 for Healthcare Coalition of Passaic County. Next slide. So the demonstration, as it evolved, really it took a village to get this demonstration up and running, to get it funded, and to really accomplish the activities of the ACOs. So I had mentioned funding from the Nicholson Foundation was critical for Passaic County, but seed money was also provided to the other ACOs by the Nicholson Foundation before the demonstration had gotten up and running. Rutgers Center for State Health Policy was deeply involved in evaluation work, a good deal of technical assistance, helping the ACOs in the early stages organize and make use of their data, developing dashboards and data visualizations and things like that. Margaret had mentioned funding at the beginning of the presentation, today's webinar. We received funding from the Agency for Healthcare Research and Quality to do a lot of the evaluation work. Nicholson supported some of the evaluation work as well. A while back, New Jersey received a state innovation model award from the Center for Medicare and Medicaid Innovation that helped with a lot of the early technical assistance and data organization. And of course, the state of New Jersey, the Division of Medical Assistance and Health Services, which runs the Medicaid program, was deeply involved in the implementation of the demonstration. And I'll also give a shout out to the New Jersey Healthcare Quality Institute that sort of served as a trade organization for the ACOs in helping get things organized and advocating for support along the way. And then, of course, the managed care organizations were involved in terms of contracts negotiated with the certified ACOs and also interactions with the ACO-like organization in Passaic County. Next slide. Okay, so I'll run through this quickly. There's a bibliography at the end of the presentation where you can find details. What actually happened during the demonstration? What did we learn? Well, one of the biggest achievements is that it created an infrastructure for communities to do broad community initiatives that involved health surveillance, and also it gave them a really tightly knit coalition to seek out further resources from grant applications instead of doing things individually or trying to sort of scramble when a grant opportunity came available. They already had the infrastructure in place so they could move quickly on opportunities. In our interviews with ACO leadership, data infrastructure using Medicaid claims and encounter data, that emerged as really the most important piece of what the ACOs got from the demonstration. Even more important than funding, which is important, but having access to the claims, being able to link the claims to other data like social service data and other things, became really important to functioning as a community coalition. The ACOs really catalyzed and strengthened intensive care management. And this is where it's kind of a subtle point. Other ACO models are set up to actually go in and manage the care directly. The way the ACOs in New Jersey Medicaid worked is they didn't actually manage the services, but they brought the people and the organizations together to do the care management. They served as really the backbone organization that got people together to convene and connect. And it's those connections that led to the actual changes on the ground. Relationships with managed care organizations. I mentioned the voluntary nature of MCO participation is really important here. This turned out to make it a bit difficult. It was difficult to align the incentives of the managed care organizations with the incentives of the ACOs under the demo. And so we didn't see a whole lot of shared savings activity between MCOs and ACOs under the demonstration. In some cases, kind of smaller, more narrowly defined service contracts were developed, but this did not turn out to be a big shared savings model as you might expect in other MCO programs. But it ultimately led to a real learning and advocacy network that supported other community health initiatives in each of the communities, and it really laid the groundwork for the transition to regional health hubs. We can turn to the next slide. Okay, so this is ultimately what we'll talk a lot about in the panel discussion. At the end of the demonstration, a shared savings model, really was not developed, and that idea was sort of abandoned, but that's okay. The ACOs just evolved into something different, and this is part of what the ACOs and the New Jersey Quality Institute ultimately advocated for. New legislation was developed and signed into law by Governor Murphy in January of 2020, about a year ago. And so what the law says is that there's now a regional health hub program that will replace the Medicaid ACO demonstration project. And so currently the hub program includes the 3 certified ACOs and the 1 ACO-like organization in Passaic County. They're now transitioned to regional health hubs. We can go to the next slide. So I'll walk through quickly what's different about the regional health hubs. So some of the features that the ACOs had under the demonstration were retained under this new structure. So it's a similar coalition structure. Community participants, healthcare providers, social services, all necessary, all take part. These coalitions, the hubs, continue to take responsibility for clearly defined geographic areas that they propose and are approved by the state. Here, there's an emphasis on care coordination, connection to social services, and community engagement. And the regional health hubs will continue to receive Medicaid claims and encounter data feeds, which they can link with other data. And this gives them the ability to do real regional data analysis, to do surveillance and intervention evaluation for all the people that they're serving within their region. Next slide. So there were a number of demonstration features that were removed from the regional health hub model. So the biggest one is that these coalitions are not ACOs anymore. The ACOs are ultimately a payment model. Under the demonstration, the regional health hubs, under the new model, the hubs are not part of a payment model. They're a coalition model. So there's no shared savings required. There are none that are really part of being a regional health hub. There's no longer a list of performance measures that are created and endorsed by state agencies, no numerical requirements for primary care or other providers. The primary care one was particularly difficult for applicants to meet, so that one is no longer required. Next slide. In addition, some new features were added to the Health Hub model. So instead of serving as independent kind of organic coalitions of providers and social service agencies, this is more of a partnership now with the Department of Human Services and state agencies. It's a model where the hubs and the state agencies can work together. So together they develop and negotiate goals, deliverables, performance metrics, and how the funding for these things is going to work. At this point, the Department of Human Services can solicit applications to create other regional health hubs in other parts of the state. That ability is in the legislation, and so it's there. We may see other health hubs in the future. Next slide. I thought it's worth mentioning that even though New Jersey transitioned to a very different model from the ACO model, the regional health hubs do look somewhat similar to other models that are underway in other parts of the country. There are some similarities to accountable health communities, which is a CMMI initiative designed to connect health and social service providers and address health-related social service needs. CMS currently is sponsoring 29 organizations nationwide under the AHC model. 2 of them are in New Jersey. The Camden Coalition is participating in this. Also Hackensack University Medical Center. There are also similar models in other states that go by different names. I listed some of the states. Many had been developed under state innovation model awards. You could do an entirely different webinar just looking at these types of organizations nationally. I think it's worth mentioning they come in multiple varieties. Thus far, the results have been mixed in terms of how they're able to move the needle on improving quality and other metrics. But we can go to the next slide. So key takeaways from the demonstration and the transition to regional health hubs. The ACO demo really provided valuable lessons for creating regional health hubs, moving to a more AHC-like model from the ACO model, which was a payment model. Now we're more into a community coalition model. The coalitions will continue with data-driven community collaborations, but without the expectations of shared savings or pre-specified quality metrics across the board. New issues as of January 2020, and then moving forward, January 2021, things that we're going to learn along the way. What is the scale and the scope of the regional health hub activities? What would be optimal? And how do you account for cross-sectoral impacts? Originally the demo was designed to move Medicaid spending and Medicaid quality metrics, but a lot of this is cross-sectoral. So, what will the impact be on things like housing and nutrition and other things that the hubs are focusing on? And if the current hubs are successful, do we want to spread them across other parts of the state? These were all issues that we were concerned about before the pandemic, but now we're in the middle of this real public health crisis, almost a year now. The health hubs were in position to really serve as a community resource during the pandemic, and this is a lot of what we're going to talk about during the panel discussion. So that's where we'll take it next. And if we could just look at the one last slide. If you want more information about any of the details of what I presented today, here's the bibliography. You can look it up and find the details in various reports and publications. But at this point, I will hand it over to Rob Houston, who will introduce and lead the panel discussion. Thank you.
Thanks, Derek, for walking us through the ACO demonstration research that you did. Hi, everyone. My name is Rob Houston. I'm the Director of Payment Reform at the Center for Healthcare Strategies. And I'm happy to join you all here today to moderate a discussion on 3 essential areas. Number 1, discussion on the Medicaid ACO demonstration project. Number 2, the transition of the organizations that participated in that project. into the regional health hub model that Derek mentioned towards the end of his presentation, and also discussing the opportunities and challenges that the regional health hubs are facing, especially those that they're experiencing currently because of the COVID-19 pandemic. So as Margaret had mentioned previously, I'm happy to be joined by an esteemed panel of folks that are probably the best people in New Jersey to be able to speak to these efforts, both as the ACO demonstration project and also the regional health hubs. The folks that are joining me on the panel today are Tyler Hausman from the New Jersey Healthcare Quality Institute, Yanae Kranzler from the New Jersey Department of Health, Office of Population Health, Carrie Lugoso Mizarel from the Greater New York Healthcare Coalition, Greater Newark Healthcare Coalition, I'm sorry about that, Gregory Paulson from Trenton Health Team, Aaron Truschel from the Camden Coalition of Healthcare Providers, and as Margaret also mentioned, we're going to have Kimberly Birdsall from the Health Coalition of Passaic County, which was the RHH that Derek mentioned that was an ACO-like entity in the demonstration period, to join us to weigh in on a couple of the questions that we'll be talking about. As also mentioned at the beginning of the webinar, we're happy to be taking some audience questions during this period of time. So if you have a question that you would like to ask the panel, feel free to submit that in the Q&A feature box there. And if we have time, we will certainly ask it. So I did want to talk to the panel about some questions that we came up with in advance, and also that some participants in the webinar submitted ahead of time. So at the beginning, we want to kind of take a look back at the ACO demonstration project, and also take a look forward to what the RHHs are doing these days. So for the group, we can kick things off with a question about the specific features of the ACO demonstration project that were most valuable in improving community-based care management, which was, as Derek mentioned, was a real focus of the demonstration project. And what, if any, features allowed social service coordination as well? Anyone want to take that question first?
I'm happy to start, Rob. First, thanks to everyone. Thanks
Sure.
to Rutgers for the invitation to participate. And, we joked as we started, these conversations, that it's been such a privilege to work with this group over the years on this project. I think some of the key features of the demonstration is, first, that they created the structures in our communities that were seated in community-based organizations that had required participation from across the spectrum that we so now clearly look at as being involved in producing health outcomes for individuals and populations, right? So acute care, ambulatory care, behavioral health, other subspecialties, community organizations, social service support. So this really gave us a call to action and kind of a banner under which to bring those together. And, our community and several others had some structures that had already started to be formed with some philanthropic dollars, largely thanks to the Nicholson Foundation and some others. But this really gave us a place to make those efforts more formal. And I like some of these analogies to AHCs or other models, but this was really seated in a community-based nonprofit that had required representation at the governance level to make sure that all these different perspectives were there.
Hi, everyone.
Thanks,
glad to be here as well. I would add to that, the structure also put us in a new type of proximity to government partnerships. So while the Medicaid ACO demonstration pilot was happening, we enjoyed the partnership of the State Department of Health, who saw the value in the ACO demonstration pilot, and then on a parallel track was seeding investments in things like engaging faith-based members of the community to improve chronic disease management and prevention, and also starting to make investments in maternal health using the structure that Greg just laid out. So, both have proven to be very helpful.
If I can just, first echo the sentiments of Greg and Carrie, appreciative to be here. The ACO demonstration project, certainly Carrie, there was the seed of all the work that was going on in Camden and Trenton and a little bit in Newark at the time. And that preceded the ACO, but the ACO demonstration project certainly gave legitimacy, particularly at the state level, to helping organize and galvanize the work that we were doing. So yes, while we ran an HIE, it enabled us to get access to additional data to expand our analytics chops. Yes, we were doing clinical redesign work, but this kind of created a focus and rallying cry behind it. And from a community engagement perspective, we had extensive networks, but this certainly held a spotlight on the types of stakeholders that we thought were particularly important to be brought into the conversation at the state level. So it really just fortified a lot of the existing work, and we're really appreciative of the opportunity to participate.
I think we should call out too the role of the Rutgers Center for State Health Policy and bringing, Derek, your team, Joel, Margaret, the academic discipline to understanding the preconditions in our communities on which we were trying to build the ACOs, and then bringing academic rigor to understanding the work we were doing at the time.
And also just to point out, we had operated in the same circles as, the folks in Trenton, a little bit in Newark, from years preceding the ACO, but we really, it would be months sometimes before we would check in on things. The ACO really codified our relationships and our ability to learn and adapt different aspects of each other's work. So, went from monthly, every so months to, we had weekly touch points around what are our learnings around our HIE? What are our policy and advocacy priorities? How should we be continuing to evolve our care management work? How do we make pitches to managed care and other stakeholders? So it really, fortified partnerships with us, with the Quality Institute, with Rutgers, as Greg was saying, and really, created a strong network across the state that we can continue to grow upon.
And for us at the Quality Institute, we were very generously funded by the Nicholson Foundation to create what we call the QI Collaborative, which is a learning network for all of the ACOs, but also the ACO-like communities. So it gave us an opportunity to really be an umbrella and really an unbiased convener for all of these groups to learn from each other, to learn from national experts, to have ACO-specific conferences, and really to go beyond the requirements of the demonstration project and really be very collaborative, learn best practices from each other, but also learn new and innovative strategies from other people that were doing similar work. And even beyond the demonstration project, all of the ACOs are now members of the Quality Institute, and we're still convening and working on things like mental health and now COVID strategies. So it really gave us the opportunity to learn from each other, but also to convene and work with, as Aaron mentioned, groups like the managed care organizations to show the value of the ACOs and now regional health hubs.
Thanks, everyone. So, Aaron, you mentioned the data aspect of things and how critical that was, and the data sharing not only between managed care organizations and the ACOs during the demonstration, but also the state data that was helpful. Can you discuss the ways that the data has been used in the ACO demonstration project, but also how it's going to be used as part of the RHH project as well?
Sure. Data has always been a central pillar to all the organizations, the RHHs and formerly the ACOs. And I think the thing that kind of stands us apart is we are all independent organizations that are bridging a variety of different stakeholders. We don't have one single set of priorities, one single focus. We are very much a neutral broker that can handle data from all these different sources and use it to adapt to a variety of problems. And so when it comes to how the ACOs use data, we really focus on as comprehensive a data set as we could physically make, and not to just draw it at the traditional boundaries of healthcare, but also think about how does that need to extend into other spaces like social services. So all three of us either had an HIE or started to really build out our HIEs, our health information exchanges. And that allowed us to bring in real-time clinical data that could let us identify individuals in real time, to be able to segment the population for various types of programs. Through the ACO demonstration project, we were able to supplement all of the clinical data we were receiving from our various providers with claims data from the ACO side, our ACO geography, to how it evolved into the regional health hubs and in some cases larger geographies. And that allowed us to tell a more robust picture of what does healthcare look like beyond just the physical walls of who's participating in our HIE, and how do we start to attach things like costs of care to some of the projects that we're doing. So that was certainly a helpful start, but then a lot of it also centered around how do we bring in data from other entities, be it the state, be it local government, be it other partners, health and social services in our communities. And so going back to that point I made about the ACO really strengthening or giving raison d'etre to the whole purpose, you know, it really kind of allowed us to say, hey, if you can give us this data, we can do X, Y, and Z with it that's focused around this. So.
Yeah, Aaron, I agree. I think that data infrastructure and our health information exchanges is really one of the key products of the ACO demonstration. So what do we mean by that? So we all operate the health information exchanges for our regions. We're on the same platform, in fact. So there's the ability to exchange both patient information and also analytic queries that we build amongst our communities. So we create the single holistic longitudinal record for each patient that's available to healthcare providers throughout the community for the purposes of patient care. But our systems also have integrated in them real-time analytics engines. So it allows us to look at all of the healthcare data combined with all of the claims data, and now increasingly combined with socially sourced or community sourced data, whether those are individual centric or geospatial data, to really understand what's going on in real time, whether that's saying where are the avoidable emergency department visits coming from, or where is the poorly managed diabetes coming from, or increasingly now in this case, where are COVID admissions coming from, where are COVID testing concentrated, where is it combined with other clinical or social comorbidities. So just having those resources in our communities, and frankly, you know, our communities don't tend to have large other institutions or resources that can do heavy data analytics, particularly within the complexity of healthcare data. So having that regional focus and the ability to make very data-driven decisions. The last piece I'd say on data is we view data not just as quantitative, you know, data points, but also the qualitative feedback that we get from our community members, either directly or through our relationships with others, including faith-based organizations, other community organizations, community groups, to really fill in a lot of what that stuff is and what it means. And I think we'll talk a little bit more in a bit about kind of how that's been useful more recently.
Great. And can I ask the group, the data gaps, like what gaps would you like filled? I mean, anytime there's data involved, it's always like, is it timely? Is it, well, it could always be more timely. Is it sufficient? Is it accurate? There's always challenges, no matter what you're talking about in healthcare data, social service data, any kind of data, even data on your home personal computer about your own finances. There's more information available.
Yeah.
I guess if you had a magic wand, what kind of data would be accessible for to you all and would be most helpful that you don't currently have?
Something I'll chime in there. We collectively are identifying a need for more of the state registry data, and the examples that we've come to through our work, specifically in the maternal child space, things like birth certificate data. We've been working on perinatal risk assessment data with some success, even WIC data, and very importantly, I think, as we learned over the summer, trying a pediatric routine vaccine catch-up effort, immunization data will allow us to maximize our role in the local level, granular data, and tailoring and targeting investments for maximum impact. So I see that as the next chapter of our work together.
Yeah, certainly immunization is particularly timely given kind of where we are for the next 6 months. And so I would echo that. I mean, there's always gaps in data within the existing data that we already get. You can think about how do we measure issues of equity? And, we've had a lot of conversations with the Department of Health around how our institutions, our data holders valuing kind of the integrity of data, in particular, areas of vulnerability, whether it be race and ethnicity, whether it be sexual orientation and gender identity. So I think part of it is improving and shoring up the quality of the existing data that we may already have, but we might not be able to use for all the purposes that we want it to be done. But then yeah, I mean, there's always new data, and a lot of that's project specific. One of the areas that is certainly top of mind on our side is around housing. So there's been a lot of work around how does the housing unstable population look like, and the health outcomes in Rutgers. Center for State Health Policy has done a lot there, but how do we get that better integrated into our HIE so we can identify people in more real time and understand their housing histories and be able to serve them appropriately to more recently, even thinking about issues like evictions and foreclosures. And we know that there's a massive influx of that's kind of queuing up and waiting to be a problem, and what's going to be the health and economic impact of that. And we've had conversations with the state around how do we potentially get access to that. So yeah, so many different sources of data, and each one of them brings new challenges and new opportunities, but we could do a whole webinar just on that if we wanted to.
I think it's important to call out too that increasingly there are not technical barriers to share and aggregate and bring together and understand those data. There's a whole continuum of legal, administrative, even kind of cultural barriers against sharing of data. And we see that even in the early work to bring institutions into health information exchanges, where there's a feeling of my data are mine and I don't, there's a vulnerability in sharing. And I think we've gone a long way, but we don't yet have all of the administrative structures and frankly, administrative will to make the presumption around data that it should be shared. Of course, with privacy protections and security protections, but that our data won't realize their potential or purpose until we're able to really bring them together and share. We have a lot of time we all spend trying to make that sharing possible, and it's quite a challenge, not from a technical perspective.
Yeah, I guess, I mean, just kind of chiming in on in that space around the data sharing, I think that one of the areas where just kind of the RHHs, I think, have been and continue to be so effective is just like showing a model of what effective data sharing can look like. I think a lot of the time, at the state level, there's a lot of yearning for more of a robust data sharing culture, and just learning the way that it's been done at a local level, I think, can be incredibly helpful to us. You mentioned, Carrie, the perinatal risk assessment, and I know that at least several of the RHHs have figured out just kind of how to crack that nut of integrating PRA data into the HIEs, and I think that just it presents a model for us at the state around how to do that effectively with our sister agencies. And then, Greg, you mentioned the qualitative as well, and I know we're going to talk about that a bit later, but just kind of the complementing those administrative data sets with the stories from the ground, and then the responsiveness at the community level, I think just kind of paints that data to stories to relationships to action loop that the RHHs are so good at.
Yeah, I think that's a really good point as well, is when folks talk about data, they usually think numbers on a screen and the quantitative aspect of it. But because the ACOs and now the RHHs are so community-based, there's a lot of insights that from the qualitative side of things that folks can gain working in the community. And I know that one of the opportunities that folks were talking about in terms of sharing through the NJHCQI forums and also other means was sharing the patient insights that the community members were saying. Would anyone want to comment on the qualitative data aspect?
Oh, I can give a kind of a COVID-related example, Rob, if that's okay.
Sure, go for it.
As we've been looking, tracking testing rates, positivity rates, healthcare utilization due to COVID, we're diving into a lot of geospatial work on where are there gaps in testing or significantly higher positivity rates, even within our small 7.5 square mile community, and identified, areas of Trenton that have specific racial and ethnic makeups that had higher rates, and trying to understand that. But then really talking to people about, why aren't you getting tested? Where, what are the barriers? What are your concerns? And, with our relationship now with Yanai and the Department of Health and other state agencies, being able to take things back, like, we heard a lot in our Latino community around, I think I might have it, but if I get a positive test, then I can't go to work. And my employer will take action. I mean, a lot of employment related concerns of I can't, we see the positivity rates. I mean, we had a point in South Trenton where we were tracking positivity rates north of 60% very early in the pandemic. And so why is that happening? How do we get more testing? And providing access to testing won't work if people don't feel they can go and get tested. So, I don't know if you want to speak. We had a great conversation. Again, this is what we're hearing. There's a lot of these employment concerns. I know that the state has done, there's some stuff about employment. How can you help? And I think that that's a great example.
Yeah, for sure. No, thanks, Greg. And I mean, it's really kind of those insights from the ground that you at Trenton Health Team and Emily Baggett and your team kind of brought from the ground, and the distress that folks were experiencing like at the testing site, and then also the distress that folks who are conducting the testing were experiencing as well, with just kind of seeing the anxiety that that the test brings up for them around, again, like you said, what's this going to do to me and my ability to continue working and supporting my family. So, the process there was, I know we have these kind of bi-weekly check-ins with a bunch of state agencies in the regional health hubs, and Department of Labor is very closely, works very closely with you guys in this space as well. And Jill Gutierrez at Department of Labor helped put together just 5 things you need to know around workers' rights, worker protections, around sort of a COVID test and a positive test result, both in English and Spanish. That's now a resource that's being utilized kind of statewide at testing sites, so that folks know kind of what's, what will be there, what safety net will be there to protect them in case they do get a positive test result. And I think that it's just like that feedback loop that you guys are able to provide from the work that you're doing on the ground, and that then hopefully, us as a state can be responsive to in order to provide just, I think, more of a compassionate response.
I'd like to add in a maternal child health example too. Learning a lot from our early experiences. We're now a Safer Childbirth Cities grantee in Newark, and purposely built in, based on the academic rigor point that was brought up before, a relationship with Rutgers School of Public Health, and built in an element of community-based participatory research that we've been evolving through all of these, the years of work. And what's so promising about that, it's having that scientific approach to interviewing and obtaining lived experience as real data. And then we took it a step further, thanks to Rutgers' help, which is, of the people interviewed, recruiting women with lived experience of severe maternal morbidity and insights about respectful maternity care. And we're going to be training them as interviewers, which becomes a workforce development opportunity. So it formalizes and validates roles of the community in new and different ways, that came about through the years of this work.
Carrie, that's awesome.
Thank you.
No, thanks for that. And of course, the elephant in the room in every conversation that we're going to have, healthcare or not, is COVID-19. And I think that the discussion has to move there at some point in time in terms of what the regional health hubs are doing. And thanks for sharing some initial thoughts on the ground. One of the things that everyone is talking about is is distributing vaccines. And wanted to get the feedback from the regional health hubs on this, and any efforts that are going on specifically in their communities, or other or things that they're thinking of that could help the process.
I mean, I can take a quick. Oh, go ahead, Greg.
No, please, Aaron.
Oh, well, so we just had a webinar yesterday on a vaccine survey that we did in partnership with the Department of Health and local providers and a whole bunch of different stakeholders, and released the findings of it. And I believe it's recorded, and we can certainly follow up with that. There's a lot of really interesting nuggets in there, so I probably won't do justice to all of them, but one of the more powerful ones was that the vast majority of the people we surveyed, they said that they want to get the vaccine and information about the vaccine through their provider. And that really sort of emphasizes that we need to spend a lot of time making sure that there's adequate training for all of the provider staff, be it an LPN, be it a front desk person, to make sure that they have the tools, resources, workflows in place to make sure that they can adequately address the competence issue that's the elephant in the room. and similarly scheduling, if it's going to be happening through the provider network, and we know that the provider community, especially if we're focused on an older 65 plus population, not as much fluency with technology, and we're talking about phone calls that then require lots of different number menus to navigate through, or internet website platforms. There's going to be a lot of work in how does the community engage these high risk populations and effectively make sure that they get brought in for a vaccine. So there's a lot more too in terms of which certain pockets we have more mistrust in, and certainly that is corroborated by a lot of the evidence base we've seen externally. But I'll let Greg, if you want to jump in.
Yeah, I had a separate example, but I think it also speaks to kind of how we look at where are the challenges in our communities. And we all have similar goals at RHHs, but we do our work a little bit differently based on the resources and kind of nuances of what's on the ground in each of our communities. Our big need, and it was back to the beginning of the pandemic, was to have a little bit more coordination amongst acute care, our federally qualified health center, and our local public health department. And especially supporting that role of local public health, where in New Jersey, we don't have as much of a robust public health infrastructure as we would like. And it's designed as a kind of locally focused effort. So when we're faced with a global pandemic, it's hard to scale that stuff up. So we started a morning call, just a half-hour check-in call with executives from the hospitals, our FQHC, our city health department, Office of Emergency Management, and then grew to include those from the county, some of the schools. And the purpose was simply just get on the same page. What are we hearing from the community? What are the hospitals hearing? How do we just coordinate our efforts and make maximal use of the resources we have? That certainly has continued the last couple of weeks in earnest around back. So it happened 7 days a week through the pandemic. We dropped down to Monday, Wednesday, Friday a couple months ago. But for the vaccine, we are a couple weeks into a massive vaccination rollout. And the reality is, in spite of the best efforts to coordinate, everybody is still, our staff are really strapped to be able to keep up. And the processes within the hospitals are a little different from within the health centers, are a little different within the health departments. So the ability to just check in and say, okay, what are we hearing today? Where's the vaccine is going this week? What's about the scheduling process? What did you hear from DOH? Just doing that local coordination in 20 minutes has proved such valuable information for our partners to all be on the same page, and then to be able to feed back to DOH and say, hey, here's a gap that we've seen. There's an additional piece of message, or, the call center at the FQHC is getting overwhelmed with this question. Can we look to the state's external messaging work to try to address it? So just that simple act of coordinating has really been immensely valuable.
I would add a precursor or maybe another component to distribution is working at the local level to engender confidence in the vaccine. And so right now, what we're going deep into are town halls and other education forums with trusted messengers where, it's an evolving process about the right message because the facts are evolving. And then being there to listen and answer questions is proving to be critical. And Greg mentioned, a few of these sectors already, but, doing that tailored to the needs of the faith-based sector, doing that tailored to the needs of the school, both staff and families, of students, we're being looked to as trusted partners. And it's not that, I think a beauty of this work is not that we're expected to be the experts in any given or all of these. It's about aligning the experts with the local need, and matchmaking is a lot of the work so that we're having honest and helpful conversations.
Yeah, I think
I just want to mention, go ahead, please.
Sure. No, that's all good. I mean, I was going to say, just kind of add on the vaccination front. I think, there's another role, here for the RHHs around sort of your, just kind of the advocacy role. And I think even just sort of in a lovingly critical way, I remember kind of a couple months back when sort of the vaccine conversation was really starting to become real and presenting this idea around some listening sessions that we wanted to do around the vaccine. And I remember two responses coming from the regional health hubs. And, and one was we were coming to you guys with hey, we have this brilliant idea. We're going to do all these. And you guys, and you're We do a lot of that. We do a lot of that all of the time. So, we can provide really meaningful feedback in that space. And I think that that's something that you guys have been able to do. But I think the other really important insight that's stuck with me ever since is that, and I think this goes back to that qualitative research question before, and my background is in qualitative. And so I think that that's why this critique kind of hit me, I think in such an acute way. As you said, you can't just listen to people here. You really have to come back and be responsive and address gaps that people are bringing to you. And I think that because of the closeness to the ground that you guys are able to provide, I think some of that feedback, it strikes deep. And then because of the relationships in the community health worker workforce that you're able to have on the ground, you're also able, I think, to provide responses to a lot of those gaps that are addressed. And I know that you guys have been able to do that on, local employer forums. Camden, you guys did an amazing local employer forum around contact tracing and certainly on the vaccination front. So I think there's a special sort of, back and forth in that space that I certainly think has been critical to the state's pandemic response.
Thanks for that. And I also wanted to mention that we've brought on as a panelist Kim Birdsall from the Health Coalition of Passaic County. Kim weren't a participant in the ACO demonstration project, but obviously now participating as a regional health hub. What has Passaic County's experience been with the pandemic and any lessons learned there?
So thank you for inviting me. And, these folks that you've assembled here are true experts and really, truly dedicated servants. That's how I look at this work, that we are here to serve, particularly special populations. And so it's really an honor to be a part of it. It's been an honor to kind of follow their progression and now to be included as a regional health hub. So thank you for this today. I think, when we talk about kind of where we are as like the less mature of the four organizations, we certainly are still trying to catch up very, very much so. One of our focuses will really be on data integration and also connectivity as we move forward this year. But in regard to assisting with the state's pandemic response, I just want to echo what was mentioned before. I think the RHHs are so uniquely positioned to be that conduit of bidirectional information. So not only to disseminate out to the community, but also to truly listen in so many different capacities through community health workers who do direct care coordination and client engagement, but through these other partner organizations and nonprofits that we convene on a regular basis and work very closely with. I think our ultimate goal is to support and empower our partners, right? We all ultimately are striving to be at a point where we can eliminate health disparities and improve health outcomes across our regions. And as Carrie said, we can't do, that's not our role. Our role is to work within the structure and make these connections. I think as far as with COVID, one of the biggest values that I've seen from our perspective is in this bidirectional information sharing with the state and with our local partners, and being able to quickly provide those insights. As Yanai said, when this topic came up, when we got folded into the conversation, it was very easy for us to be able to draw on past experience, to be able to say, this is what this community may need, this is what, and we'll do more digging, but this is the experience. So I think it's ever evolving. We have also been really grateful to be able to do this work and really share not only information, but connection to true resources through the tools that we have as an RHH. So gaining insights about the changing needs of individuals and also being able to connect them to resources that have also evolved due to the pandemic. So I think I probably have more to say. I always have too much to say, but that's kind of where I would end for now.
Thanks, Kim. Yeah, it seems like we're saying a lot on this webinar, like, oh, there could be a whole nother webinar on this. So definitely opportunity to continue the conversation through other means. I did want to kind of pivot a little bit to, it's obviously related to the pandemic, but at the same time, more about the structural model that the RHHs provide. So obviously, as he was going through his slides, Derek was talking about the transition from ACOs to RHHs, and that the RHHs are more like accountable health communities in other states and the CMS model. why do folks on the panel think that the transition from ACOs to RHHs was necessary? What are the improvements that were gained? Derek went through some of the changes, but in terms of where you all are sitting, why was this a necessary change?
I think one of the first was helping people and organizations understand our role. You know, under the Medicaid ACO, we all found ourselves beginning meetings saying, we're Medicaid ACOs, but we're not really ACOs because ACOs are a payment model and we don't really have any payment yet. So I think that was really the first piece. And as we, you know, worked a lot with some leaders in the state to kind of work through and establish what that regional health hub and enabling legislation would look like, having the right framing so that people would understand what is the intended impact and value of these organizations was really key. So I think that was one of the biggest. And we saw, you know, quite a bit of kind of more ease of engagement and I think kind of faster route to impact with the more proper framing of, frankly, the work that we had been doing all along through the demonstration.
And if I could just add, I mean, not being kind of pigeonholed into this shared savings generated kind of only purpose and obviously improving quality, but you know, I think it certainly forced us down a lot of pathways that we weren't necessarily equipped, and it kind of overshadowed a lot of the really strong things that we were doing on the ground. So, you know, as Derek was saying about not seeing shared savings, and as we got into the weeds of it, you know, we saw a lot of spending on things like expensive pharmacy use. So, you know, can the Camden Coalition, the Trenton Health Team, Greater Newark, can we help keep Hep C spending down? Or is that even a problem that we're getting this really innovative treatment potential out to the Medicaid population? So, you know, that's a problem that, you know, was better addressed within the provider community and within health systems that, you know, have the capacity to, you know, handle scheduling, handling prioritization of people for certain types of treatments. You know, we certainly handled the care management piece, I think, as well as could be done because, you know, we bring that very holistic perspective to what does an individual with complex medical and social needs look like. But it certainly pulled us back into the areas where we were strongest and allowed us to kind of free ourselves of a burden that I think, you know, we were kind of not necessarily as equipped as we could be from the get-go.
And in Newark, we struggled with a population density challenge under the ACO, where Derek mentioned the 5,000 Medicaid enrollees. That ended up being 3 zip codes within Newark. And so the it was an artificial limitation just because of the nature of the ACO. The regional health hub now allows us to be more regional. So we are all city of Newark, East Orange, and Irvington, and even, you know, peripherally beyond that. And I'm seeing similar shifts in approach with our sister coalitions where they're looking more regionally in a more comprehensive way.
At the Quality Institute, we recognized even before the demonstration project ended that there was really going to be a need to evolve and pivot for a lot of the reasons that Derek mentioned. There were a lot of challenges like the focus on an outdated fee-for-service population, the lack of incentives for MCOs to contract for a number of reasons. And we got together under the Medicaid 2.0 blueprint, which I know many of you know, to talk about that evolution. And we all convened together for the better part of a year to talk about what the regional health hub model would look like. And it was clear that really just greater flexibility was needed, a greater partnership with the state was needed to work on like priorities for these communities, because all of these communities are so vastly different and they can share best practices and learn from one another, but there really needs to be an ability to implement different strategies and work on different things in each community. So I think that's really what the Regional Health Hub legislation has done, is to create that greater flexibility and a more important partnership with the state.
Great. So it seems like there's, I mean, obviously the RHHs, there's a similarity to accountable health communities models. A lot of the accountable health communities models, it's not a one-to-one comparison, but there is some similarities in terms of the structure. Definitely more AHC than ACO at this point for the regional health hubs. One of the things that has been mentioned as a challenge to AHCs across the country is the challenge of sustainability. And when you don't have the pressure to generate an ROI or shared savings or something, that's really great. And it allows you a little bit more flexibility on that. But at the same time, you know, like there's still funding that's necessary to do this kind of work. So with a large audience on this webinar today and a broad array of stakeholders here, I'd like to ask the panel what their comments are on how different sectors can continue to support the work of RHHs. It doesn't necessarily mean financial resources, but financial resources are obviously a consideration, but also, you know, just to support in the communities.
I'll jump in. You know, there's a commitment among the RHHs about leveraging federal investment. And so thinking about what resources exist at the federal level, how do we optimize matching of dollars so that, you know, New Jersey can stretch its dollars further. And things are, you know, it's coming up. We're learning a lot in the technology space, things related to the statewide health information network and some mutual interests we have in the success of those in that and the regional health hubs. So I would add that into the conversation, something we're very committed to and need for sustainability.
I also think the infrastructure and the direction that the state is going into with the community health workforce, with workforce development as CHWs, these are critical roles that we really do need to look at a larger, higher level scale to pull into our workforce here in New Jersey. You know, and I think that there is an existing infrastructure that is there. We just need to move forward to take advantage of it. So I do see that as, and also continuing to work with payers across the state and have support in those conversations and these types of pilots to use what's effective.
Spend a lot of time, I think all of us, looking at the value proposition of our work and, you know, really making sure that what we're doing either direct for our community or with partners is helping everybody achieve what they're trying to achieve better. So part of our role in the Trenton community has really been to facilitate the work of some of our partners, in particular, some of the smaller community organizations who might not have as many resources. So that could be just with our director of grants and development, keeping an eye on what funding opportunities are coming up and then trying to match those actually, not necessarily to us, but what would be the best organization in the community that might have the best chance, and maybe even give them some support in preparing a stronger application, because the goal is to get those philanthropic dollars into the community to result in a successful program, whether it's through us or somebody else. Similarly, we've recently built some data analytics capacity outside our health information exchange in our organization. It's actually been a key part of our COVID response, similar to what Aaron and team have built in the Camden Coalition. So just a few examples of, you know, how can we coordinate the work of others, because we know that the work around health and well-being in our communities is going to come from multiple different sectors for the foreseeable future. If we can make those sectors work well together and make those organizations more effective, then there's a net benefit for the community.
And I think
Great,
a pillar of the work has been also the public-private partnership. So, you know, we mentioned some foundation support, Healthcare Foundation also weighed in earlier, and they've been doing local support. So I think we do have a responsibility as hubs to make the most of whatever government resources are available and then scrub the philanthropic side of the aisle to make the most of both types of investments.
And truly that philanthropic support for us, we would not be here if it was not for the generous support and of philanthropic organizations. And it really is critical to us getting started and continuing to move forward. So I echo that, Carrie. And also just from a broader perspective, you know, the pandemic has shed a light on all of these disparities, on all of these inequities. And so I do believe that using the regional health hub structure and the knowledge that we have, you know, there is an opportunity there for us to now be able to bring in some other funding to really start to move the needle and end these issues, you know.
I would be remiss if I didn't just qualify with one sentence. I think I just want to be clear to the audience. It's not, we're not taking this from a charitable approach. to Greg's point about the value proposition of the work, it's really, we have to make the business case for this. This is not a feel good, endeavor. So I think being rooted in the data and all of the outcomes impact is where the future of this work is.
Yeah, and I think that's a good point, Carrie, because a lot of times, like when you have a shared savings calculation, you're calculating medical expenses and not community benefit or things like quality of life or addressing health disparities in the community. So there are some things that this structure allows that is a little bit allows you to experiment a little bit more and allows you to do things that aren't typically medical. So that is one advantage of this as well. So I know we are running short on time now. I did want to turn it back to Margaret, who I know has been monitoring the question and answer chat box. I know that we've hit on a couple of different things that were suggested in the Q&A, but just wanted to check in with Margaret on some others that might be interesting.
Great. Thank you very much, Rob. And thanks for the questions coming in from our participants. There are a couple of, as Rob said, I think much of what was discussed hit on a number of the questions, but a couple of things that I wanted to raise. One, a little bit more technical, but I think it was because we did get, not surprisingly, a number of questions about the vaccine rollout. We would anticipate that. One of the questions was around, and I don't think that I'm not sure what the response would be at this point, but maybe just a clarification that one of the challenges is in this rollout and trying to identify the vaccinators, the folks who can do the vaccine, administer the vaccine. There has to be some oversight right now. Is that the way that the regulations in New Jersey are written? So is that potentially an additional challenge of maybe pulling out, Rutgers nursing students or pharmacy students or med students, but then there is some regulatory issue there in terms of the oversight that would be needed for people to administer. Is that accurate?
Yeah, absolutely. That oversight is very much built into the process. And if folks have just kind of additional questions, of course, they can kind of reach out in terms of what some of the details of that process looks like.
Okay. And I think that's one of the challenge, but one of the benefits, right? This is still a vaccine administration. There needs to be oversight. I mean, yeah. I think everybody would love to just round up people and say administer a vaccine, but those protections still need to be in place. Is that fair? Right.
I mean, that is like the challenge here, is how to figure out how to ensure that this vaccine can get to folks in a way that's accessible, that's supportive, that's safe, and to ensure that that's done in a way that ensures that the vaccine can still be effective and there to be distributed and disseminated in the spot where
it's speed and safety, right? I mean,
yes, speed, safety, accessibility, trust.
Yep. Exactly. So thank you for that. A couple of questions came in that I really, under the same rubric, if you will, that I think is really important. But a couple of questions came about structural racism and the conversations that we've had over the last year, and institutional biases, the disparities that exist. How, if at all, how has your work changed of the regional within the regional health hubs? Do you go about your work any differently after the conversations in the last year and thinking about some of the structural barriers, the as I say, institutional racism, the disparities that frankly have just been highlighted in great quantities over the last 10 months? Can you reflect, either personally or representing your hub, your organization, how it has changed the way that you approach the work that you do?
I'd be happy to start there. And I have to give tremendous credit to our team and our community who were, throughout the time when we're all working remotely, and there's all of this, the real focus on social justice nationally, who stood up and said, we have issues we need to look at internally. We at Trenton Health Team have 4 white senior leaders. Looking at our panelists today, looking at the leaders of our 4 regional health hubs, we are not, from a racial and ethnic perspective, representative of the communities that we serve. Our organizations, in many ways, have some who are, and we have current residents, we have former residents who are still very committed to the community, and we have others like myself who don't live in the community but are very committed to doing our community's work. So I think we are far from perfect or far from where we want to be, but we see all of this in our data. We hear it from our communities, we hear it from our staff, and we are very, very deeply committed to doing the work, starting personally, internally, and then really using all the resources we can to highlight this message and the importance of this work. You know, I feel so blessed that we have gotten such support from our team and from our community. And sometimes that support is saying, hang on, this is wrong. You know, bringing that up to us, and if it's something we're doing wrong, that is still done in support. And you know, we've come a long way as an organization in the community, and certainly have tremendous more to do.
I would say echo that 100% plus, and the power of listening has just become such, you know, it was clear and clearer, and, you know, keeps going on that continuum. And to Greg's point, it's listening no matter what the perspective is, and accepting that as a data point. And so if the current way of doing something is off track or not the best it could be, taking that in, because one, we have to worry the day we stop hearing that feedback, because hearing feedback is a showing of respect and trust, right? So the more we can engender that honesty and reality-based feedback, it's only for the better. So I think, you know, doing as much of that and, you know, modeling that within our staffs and within our communities is really leading by example, and an opportunity here based on the framework that was put into place in law and how we operate in our 4 hubs. I've never worked with a more collaborative bunch of organizations and partners. And that in and of itself is something to hold on to and keep doing and doing better.
If I can just, go ahead, Margaret.
No, no, please.
I was going to say, echoing all that as well. I mean, you have to start inwardly looking, and, you know, I think every organization has its problems. And, you know, I think the regional health hubs, you know, we all kind of started this work from a very community focus, and doing that kind of care management work where you're serving some of the most high needs individuals, I think is very humbling, and certainly gives you firsthand experience to be rooted in. I mean, I think when we think about things like evaluation, and we're talking about shared savings, what's the value proposition? We think such, you know, purely financial. You know, one of the conversations we have is, you know, when we just had a high-profile randomized controlled trial that didn't show an effect on readmissions, and when we went back to our community stakeholders, our advisors, our former patients, and said this and asked them if they thought that was important, they said, you know, we don't care about readmissions. That's not, you know, if this is, you know, when we think about this, this is the lifetime accumulation of underinvestment in schools, in the prison, you know, criminal justice pipeline, and underinvestment in primary care, social well-being. And so if we're talking individuals who've accumulated so much injustice in their lives, and you know, the cost of that isn't, you know, one extra hospitalization or what have you, you know, it's kind of minimal in the grand scheme of things. And so I think it certainly opened us up to not in, you know, and I think the ACO to RHH shift certainly facilitates this, but not just being so rigidly minded around kind of reducing costs.
Terrific. Thank you. I think that's a great answer. And frankly, I think that's an appropriate way perhaps to close this conversation. So much more work to be done. But, you know, I think the efforts put forth from your organizations, we're headed in the right direction. And Carrie, as you said, you know, the collaborative approach, it's shared mission, and it's, you know, it's really all pushing in the same direction. I think for myself personally, in the spring, as horrific as it was, I never felt a greater sense of solidarity with people, in terms of people weren't fighting over the small stuff. Things were getting done, and it truly, I felt unifying as a state. And of course, as things kind of get back to more try and head in the right direction, then you see the squabbles, but it can be done. And the energy that comes from that commitment to the same cause, and whether it's social justice issues, whether it's you know, trying to deliver and improve an equitable healthcare system, you know, we can't be discouraged by the steps, even when they're smaller than we want them to be. We have to acknowledge them, and hopefully we continue to work with people like you. So again, thank you very much. We got to some of the questions, did our best to try and touch on the questions that were posed by the audience. Appreciate everybody's time. Frankly, it's the most valuable commodity anybody has these days. So spending an hour and a half with us hopefully was a good investment for everybody. We really appreciate it. Please be on the lookout for invitations to our upcoming forums. Thank you all again. Stay well and take care, and we look forward to seeing you next time. Bye-bye.
Very much. Bye-bye.